Good afternoon and welcome everybody to another installment of Probing the Literature, the Ultrasound Journal Club that is sponsored by the SAEM and ACEP. And so this month we're going to be specifically talking about airway and resuscitation. And our first article, we're very excited to have Dr. Dallas Holloway with us. And so we're going to be talking about the accuracy of ultrasound for endotracheal intubation between two different transducer types. Dr. Dallas Holloway is the medical director and the director of ultrasound at Providence Seaside Hospital in Seaside, Oregon. And she's going to be talking to us about her article today. And I'm going to stop share and turn it over to you, Dr. Holloway.
Unmute myself here and get my slides up. All right, well, hi everyone. Thank you so much for the invitation. I appreciate it. Always excited to talk about a little bit of ultrasound. As mentioned, we're going to be focusing on airway and resuscitation. So we're going to be covering this article from the American Journal of Emergency Medicine and looking at accuracy between different transducer types for endotracheal tube conformation. So kind of first thing I wanted to talk about is sort of why did we decide to look at this topic? And there are a few reasons. So we know that intubations are commonly performed in the emergency department. And the gold standard that we typically look to when we're looking for confirmation is our Untitled Capnography. But there are a couple of scenarios where this may lead us astray and may actually complicate our airway situation. So firstly, when we're looking at a cardiac arrest, that Untitled just might not be accurate. And I've personally seen this a few times in my career when someone's come in with a massive pulmonary embolism because of that VQ mismatch. Even though that tube's in the right spot, your Untitled is just not going to change. And so in that scenario, you may pull a good tube when it was not inaccurately placed. And then, especially if that was already a difficult airway, now you're struggling again to get that tube back in the right spot when you were right from the get-go. Also, if the tube is in the hypopharyngeal space, you may get a false positive or a false confirmation that your tube's in the right spot when actually you're not. And so you don't actually have a secured airway, which could definitely complicate your resuscitation. And then probably lastly, and somewhat most significantly to me, is that this method requires insufflation. So you have to bag the patient. And if you're looking for color change, you may have to bag them up to 8 times to get that change. And if that tube is in the esophagus, you've just insufflated the stomach with a bunch of air. And when you pull that tube out, you've significantly increased your risk of vomit and aspiration. And the few times that I've had this occur, the best way to take a pristine airway and turn it into a nightmare is to fill it with something like this, where you just can't see anything. And now you've put yourself in a much worse situation because you had to do that bagging. And if you can potentially skip that step, that might save you a lot of pain down the road. So there were already some existing studies looking at this, but they really use a mix of probes, primarily the curvilinear and the linear probe. So what we really wanted to determine with this study was, is there a difference? Was one probe better than the other for verification? And then we looked at a few secondary outcomes, such as time to verification, operator confidence in the verification, and then just operator preference. So how did we do this? So this was a randomized blinded study. It was performed in the cadaver lab at an academic hospital in Chicago. So we essentially had 3 cadavers, and we wanted to have multiple cadavers because when we talk about point of care ultrasound, one of the big things we talk about with patient demographics is always size, because we know if we're increasing the amount of tissue between that target that we're trying to look at, it's potentially going to make things much more difficult. So we wanted to have a wide variety of neck circumferences to actually accurately reflect the population in the emergency department. So we determined the intubation, esophageal versus tracheal a priori, which is a random number generator before we started to make sure that we didn't introduce any bias. And then we had a study assistant who was present the whole time, was timing and recording tube placement, operator confidence, all that information. And then we had an emergency physician who was performing the intubations with video laryngoscopy. And then we had 4 sonographers, or emergency medicine physicians that were doing the sonography to determine the tube placement. And one thing we really wanted to be careful about, since we had a lot of people sort of rotating through and doing a lot of tasks, and there were people who knew some information and people who didn't know that information, is that we wanted to prevent any sort of bias. So the intubating physician did all their intubations alone, then they left the room, then sonographer 1 would come in, perform their study, leave, sonographer 2 would come in. That way we weren't giving anyone any nonverbal cues that might bias our determinations. And then we recorded all that subsequent information as far as time, confidence, et cetera. So this is essentially what we would see when we were looking with the linear probe. So when we were doing the sonography, we would basically start by placing the probe on the middle of the neck, and then we would slide from side to side to view that esophagus, and then we would perform a slight twisting motion. So here you can see, I hope you can see my mouse. This is what we would look like with the linear probe. So we've got the trachea here. It's an air-filled structure. So you're going to get shadowing behind it because we know ultrasound can't penetrate through air. And then we would look from side to side. Typically, you're not going to see the esophagus if there's nothing in it. And then over here, you can see we still have the air-filled trachea, which is what we expect. It's an air-filled space. But then just lateral and posterior to that, we have this sort of second, almost mini trachea, another air-filled space that's where we wouldn't expect it to be. And that's because there's a tube in the esophagus. So you can see that the linear probe is really giving us some nice detail. And then this is a video of that twisting. So just to create that motion artifact so we can really pinpoint where that tube was if there was any question. And so you can really see that nice movement in the trachea on the image on the left. And then you can see where we have that double air tract. You can really see that motion artifact in the esophagus itself, where it's definitely not supposed to be. And then compare that to images with our curvilinear probe. So of course, we know this is going to give us more depth, a wider view. And so over here on the left image, we've got the trachea. So we have a single air-filled structure, which is what we want if that tube is in the trachea. And then we have that sort of double air tract sign when the tube is in the esophagus, so not in the right spot. And then this is an example of what we get with that motion artifact. So over on the left, we've got the motion in the trachea where we would like to have it. And then on the right, we've got that double air tract sign and then motion in the esophagus where we certainly do not want it to occur. And so again, just to highlight from earlier, at no point during this verification process would you have to perform any rescue breaths. So what did we find? So we performed 405 intubations, which is quite a lot when you're doing it all in one day. 207 of those were esophageal, and then 198 were in the trachea. We really wanted to make sure those numbers were about even. Overall, ultrasound was 96.5% accurate, so fairly accurate, with a mean time to identification of 9.53 seconds and a mean confidence of 4.64. And then when we actually break those numbers down based on linear and curvilinear, we can see that the linear trended towards a little bit more accurate at 98% versus curvilinear that was at 95%. This wasn't statistically significant, but it is just worth commenting on. And then the time was significantly different between linear and curvilinear. So a mean identification time of 7.46 seconds with the linear probe versus 11.63 seconds with the curvilinear probe. And then we can see that the operator confidence was also higher with the linear probe at 4.84 versus 4.44 with that curvilinear probe. And overall, all the sonographers preferred the linear probe to the curvilinear probe, which is not particularly surprising given those numbers. And just to sort of go back to our images and get a sense for why I think that that time and the confidence was higher with the linear probe, you can see the linear probe is really giving us quite a bit more detail compared to that curvilinear probe. So I think that's really why we saw the difference in those numbers. So you could get to the right answer with the curvilinear probe. It just takes a little bit longer because the detail is just not as fine in the image. And then of course, whenever we talk about a study, we have to really talk about the limitations. So firstly, this was a cadaver study. However, there's a fair amount of literature to support the conversion between cadavers and live humans when it comes to point of care ultrasound. So it's worth noting, but we didn't think it was fairly significant. I think one other hiccup that we ran into a little bit is that we really were hoping for a large amount of variation in our neck circumference. and we didn't quite get it. I think the variation, we had a 230-centimeter necks and about a 40-centimeter neck. So maybe not completely reflecting the entire ED population we would see, but we at least did have some variability there. We also used a Zenari machine, which is a fairly nice machine that's probably a bit nicer than what you have in most community emergency departments. So there may have been a little bit more level of detail there that you might not get with like some of the smaller, more portable machines that you'll see out in the community. And then lastly, probably the most challenging piece of this paper was the training of the emergency medicine sonographers involved. So we'd all been trained on ultrasound verification for endotracheal tube placement. And then additionally, we were all ultrasound fellows. So it's difficult to extrapolate how this would apply to the general emergency medicine physician practicing public, because a lot of folks probably don't have experience in this regard. But it provides a nice platform for future studies, because we've determined that linear probe is probably the way to go. So if you wanted to look at training a novice emergency medicine physician in this technique, you can probably just throw the curved linear probe away and stick with the linear probe. But definitely a future area of consideration. And that is about all I got. There's my contact information. So if you have any questions or anything, please feel free to reach out. And I'm certainly happy to answer any questions as best I can.
All right. Thanks so much, Dr. Holladay. I have a couple questions for you. And so if any of our audience has any questions, feel free to put it in the chat or you can pipe up. So I guess my first question to you is, so have you done any follow-up studies since the cadaver lab on actual patients? And is this something that you use in your practice on a daily basis?
To my knowledge, they have not followed up with live patients. I think potentially, I would say the next launching step from this paper would be potentially doing a training program with general emergency physicians that aren't fellowship trained, that maybe had their residency 10 years ago. So it's be a really new concept for them to kind of hone in on what would be the best training program.
Great.
I think one of the areas that this is best for practice is especially if you are potentially working with learners, because you can, while the learner is intubating, sort of independently verify that they're exactly where they think they are without having to kind of hover over their shoulder or, barking at them. What do you see? That stuff from our training. I think it really has a place in the academic center. Where I practice, I am, as you can probably guess by the number of hats that I wear, we're a small critical access hospital. So I'm sort of doing resuscitation procedures, all of that in my practice. So I don't know that this is necessarily something that I jump to. I would certainly consider it in those scenarios where I'm not getting that end tidal that I expect. If I really didn't, if it was a difficult tube, I really didn't want to pull it because I was pretty sure I was through the cords, that would probably be something I would go to if the capnography just wasn't matching up with what I saw.
Excellent. Okay, great. And then I actually thought it was interesting because do you feel like the twisting motion, because that's actually something that when I first had heard about this, no one really had taught me that. So that was something that when I started looking into this topic further, that twisting motion seems to kind of help to really help identify which place you're in. Do you feel like that may have skewed your results any, or do you think that that was essential? Did people use that, or was that something that, is such a standard piece that it didn't make a difference if they twisted or not twisted?
Mm-hmm. So we were following a protocol. So there was a twist in every assessment. I would say, just from being one of the sonographers performing this study, there were times where I didn't even need it. It was just so obvious when I was looking at it. So I think it's one of those nice little verification tools where you're like, I'm not 100% that I'm right where I think I am. Okay, I gave it a twist and I saw that motion artifact. And now I know that I'm actually where I thought I was, or hey, I'm not where I thought I was. But I don't know that it's essential.
Okay, awesome. Let's see, we got a couple of people in the chat. So Tom Jacob is asking, do you know how the cadavers were preserved and if that impacted your findings? Great question.
That is an excellent question. And I have no idea. They smelled like any other cadaver in the cadaver lab. So I assume it was standard. I think you've got there was a little bit of desiccation. So certainly, the tissues probably weren't as, for lack of a better term, as juicy as you would be in a normal person. I think that kind of goes back to where there have been previous studies that have shown that POCUS results are really applicable, even if you're looking at a cadaver, to real life people. I think that the tricky part is that we didn't really have any super fluffy necks. So we didn't really have an ability to say, hey, if you've got this, really large person who has a challenging airway, maybe you're not sure it's in the right spot, but you really don't want to take it out. We can't really say that this would be amazing for them, unfortunately.
Okay, and it looks like Mike chimed in on that, saying that they were not preserved, fresh frozen.
Oh,
so
there you go.
That would probably
Thanks,
account for some of the desiccation. But no, it's actually, that's a great question. I had that question as well. It looks like Dr. Melnicker, you have a question?
Yeah, I could not quite hear what Dr. Holladay was saying about the probes. My only comment is similar to Sandy Werner. We did this in the OR with new anesthesia residents in July who miss. And we were able to find 100% of the misses. But I wasn't clear on what you were saying about the comparison between the linear and the curvilinear probes, if you could repeat that.
Yeah, so what we wanted to look at, so there are some existing papers, and I think we actually read that paper for our background, but there was a mix of probes. So some folks were using the curvilinear probe for their papers, some people were using a linear probe, and so what we wanted to look at was one probe superior to the other? And so that way we could sort of guide further work towards more accurate probe potentially, which we didn't really, the accuracy was comparable between the linear and curvilinear, but the time and the confidence really favored the linear probe.
I see. Yeah, I'm not sure how many people have linear probes, but I'm hoping that the number is steadily increasing. This versatility of linear probes, whether it's looking at the airway, you can also use a small footprint probe as the basis for your crite pressure and actually watch the ET tube as it passes in a dynamic fashion. So the linear probe is helpful. You can look at lung sliding, and the linear probe is usually superior for that as well. And the opportunities to use the linear probe for other musculoskeletal related viewing is going to be a big deal in the near future.
Yeah, I think with now that ultrasound is really standard of care for central line placements, I think most sites are going to have a linear and probably a curvilinear. My guess is phased array might be the probe that's left out if you're really trying to keep your costs under control.
Yeah, I think nowadays most people will have two probes. I would think in the community at least. Let's see, I got a couple more questions for you here. Sandy Werner has said that they did a similar study in the OR many years ago. We found some variability in the location of the esophagus. Did you encounter this between the cadavers?
Yeah, oh man, I can't, Mike probably knows the stats off the top of his head, but I believe that the esophagus is usually on the left, I want to say. And I think I want to say all the cadavers were similar, but it was a couple of years ago, so I may not be 100% on that. Yeah, but that's why we went from side to side as part of our protocol, like quick slide left, quick slide right.
Yeah, that's really interesting. We did like, I think we initially were going to do 50 patients in the OR, and we had an anesthesiologist behind a curtain randomly intubating either the esophagus or the trachea. How we got this through the IRB, I don't know. But and then we had two sonographers who were watching the intubation on the ultrasound only, and we, said where it was, and only one intubation. And we had most of them on the left, a few on the right, and we had one esophagus that was immediately posterior to the trachea. And that was really the only one where we had any challenge at all identifying it. But it was the only one, and I was just curious if you had any cadavers that were like that. Thanks.
Yeah, that would certainly confound things. I would think that might be where you'd be able to rely on that twisting, because you wouldn't see that great artifact in the trachea if it was behind the trachea, just because of all the air shadowing. But yeah, that would certainly complicate things.
All right, great questions. I have one more for you. And so since this was your fellow project, is that correct?
I think I was actually an attending at this time.
Okay, at the time. Okay, so early career then. And so I think a lot of our viewers are fellows or early career attendings. And do you feel like this was a way for you to kind of help you to publish more papers on the same topic? What did you feel like you were able to kind of use this to help you to, and how did you do that to publish more papers on the topic?
So we did quite a number of ultrasound airway papers, looking at like endotracheal tube size, twisting, linear versus curvilinear. So it's really nice if you can find a topic like this that hasn't been fully explored and just really explore all the facets of it, because there are many, especially if you take the time to look. And so you can really like drill down on those details. And then again, you know, looking for future studies. So I think this would have been a next step would have been saying, great, we know that linear probe's better. We can go ahead and get rid of the curvilinear probe. Now let's take a bunch of physicians, train them to do this, and determine exactly what's the best training protocol. That way people could actually roll this out at their facilities if they felt like it was something that they wanted to do.
It's a great point. I love that. I think that's what's great for our fellows and whatnot, and young faculty, really trying to think of a project and how that answer, when you get those answers, that may give you an idea for the next step and the next project. And I think that's something that's super important. Awesome. All right. Does anyone have any other questions for Dr. Holladay? Okay, that was a great article. I love that, you know, how this really kind of helped you to determine, you know, what's the best way to review or to view your intratracheal intubation. And I think that using this, we've done this at my shop where we have residents, like using that and say, like, let's guess who's in. It's kind of a great use for that tool.
Absolutely.
Awesome. Well, thank you so much for being with us today. I know you have a shift. You're welcome to stay for the next half of Journal Club, where we're going to be talking about another study. If you have to bop out, we totally get that. We really, really appreciate you being here today.
Yeah, thank you so much. I appreciate it.